Kia ora tātou, everybody. Bruce Darrell's my name. I'm the director of the Goodfellow unit, and it's my pleasure to introduce Professor Jamie Kitt from Oxford. He's a cardiologist, general internal medicine specialist there. He's going to be talking tonight about postpartum hypertension, which has been a major research interest of his, and he's published in some very big journals, Circulation and Journal of the American Medical Association. He's visiting New Zealand. We'll be giving a talk in Dunedin in a few days. So, Jamie, welcome to Auckland, and we're looking forward to your talk.
So, as Bruce says, I'm a cardiologist, but with a special interest in obstetric cardiology, and my research interests over the past decade have focused around preeclampsia, gestational hypertension, and how we can try and improve outcomes following pregnancies affected by these two conditions. A couple of abbreviations, just because as cardiologists, we love three-letter acronyms. So these will spring up throughout some of the slides. So cardiovascular, blood pressure, HTPs is coming up a lot, because for me to say hypertensive disorders of pregnancy repeatedly is quite a tongue twister when I'm jet lagged. PET is a common acronym for preeclampsia, and GH for gestational hypertension. And the only other one that we like a lot in cardiology is MACE for major adverse cardiovascular event, which covers all sins from heart attacks to non-fatal to heart failure, just non-fatal strokes and death. So what are we going to cover today? So we're going to cover these 6 key points. Why are we talking about this issue? Why does hypertensive pregnancy matter? What do the current guidelines say from Europe to UK to America to your own guidelines from SOMANS? What does the current real-world data suggest about the current levels of care we're providing across these areas of the world? What does the latest trial evidence, some of which is mine, suggest we should be doing going forward? What's my practical advice for those of you who are looking after women affected by these conditions, and what you can do in the real world to really optimize their care? And then how can we align the latest trial evidence to real world practice in New Zealand? And I think that's going to be the biggest discussion point at the end, because I've only really had 3 days since I landed Sunday to get to grips with actually what's happening in New Zealand. And please accept my apologies for any mispronunciations of Maori words. So why are we talking about it? Hypertensive disorders of pregnancy are incredibly common. 1 in 10 worldwide. If you're African or Caribbean, it's 1 in 9. And there isn't any clear data that I could find within the Maori population, but we'll see some data from Sue Warren later that suggests it's probably around 10%. Both types of hypertensive pregnancy have a significant impact on the mum and the baby. We're not going to talk about babies in this talk. Both peripartum, postpartum, i.e. afterbirth, and long-term. We know from huge cohort studies that 1/3 of women will represent within the next decade with hypertension. But this is not the whole story. There's a doubling in the risk of cardiovascular disease, traditionally thought of as heart attack, but there's a lot more risk that's become apparent in the last few years. And it's not just the heart. There's a doubling in the risk of stroke, vascular dementia, and chronic kidney disease. When we look back to the heart specifically, I promise you this is the only really cardiological slide with a picture of the heart. There is a hazard ratio of 1.8, i.e. almost doubling in the risk of coronary artery disease and heart failure. And typically this is the type of heart failure where the heart's become stiff, which is called HFpEF. There's a significant increase in the risk of valve disease. We don't understand the 3-fold for aortic stenosis and 5-fold for mitral regurg, which is huge. So why am I talking to you about this today? I became interested in this during my training and during my PhD in Oxford, and the group I was working with, which was Paul Leeson's group, had noted that HCPs are associated with significant adverse remodeling, that when they compared people who had a normal pregnancy, i.e. a normotensive, to a hypertensive pregnancy, those who had a normal, all the changes you see in the heart and vascular system return to normal in 99% of people, whereas in people who've had a hypertensive pregnancy, this was certainly not the case. And in those where there was abnormalities in the heart that were present in the 6 weeks to 6 month period, there was a strong correlation to having premature heart attacks, heart failure, valvular disease. So this led to the hypothesis from our research group of what can we do? Could better control of blood pressure improve the blood pressure long term? We know from big studies done in the US and Norway that blood pressure is a big driver of many of the other risks, such as heart attack and heart failure. I didn't know why the slides just jumped. Bear with me, sorry. We knew that if we improve blood pressure, this potentially could improve cardiovascular remodeling, as it does in general adults, and it could reduce long-term risks. Richard McManus, who's a professor of primary care in Oxford, had shown that self-management was really effective in many other conditions, whether it was stroke, CKD, or general primary care. And he published 4 to 5 trials, many of which were in the Lancet, called the Tasmin trials. So we collaborated with him and thought, if we do self-management and we do it well in the postpartum period, can we achieve better control, and can we alter the risk in this young, motivated cohort? So let's take a little jump across to the guidelines. So your guidelines, which I think are the best of the guidelines, I'm not saying that just because I'm in New Zealand, but having looked at them all in detail, they are, and I'll say why, you get 2 gold stars. So all of the guidelines say that women should remain under close monitoring, recognizing that the first 48 to 72 hours after birth, when you've had preeclampsia or gestational hypertension, your blood pressure is very labile, and sending someone home is a little bit risky. Your guidelines recognize that there's no clear evidence of one drug being better over another, and that's currently being investigated in other studies. But there is a bit of data that enalapril may be a good drug, and in the UK, we've been using it as first line for 6 years, and your guidelines have taken that on board and note that it's now an option. It says before hospital discharge, women should be cancelled about their long-term risks. Our guidelines say the same. When you speak to women who've been through a fairly traumatic pregnancy, they don't want to be told that they've got a risk of heart attack and stroke at the time they're going home, when they're trying to get to grips with breastfeeding, changing nappies, and having a cesarean scar. It says that a healthcare professional, whether it's a midwife or we call them health visitors in the UK, I think is a similar term here, should see people within a week of discharge to check the blood pressure stabilized, and various guidelines will recommend something between day 3 and 5 and 7 and 10. And then this is where your guidelines were better than the others. So your guidelines say at 3 to 6 months, you should do these things: blood pressure, and ideally a 24-hour blood pressure. And that is a real gold star for me, because 24-hour blood pressure is the gold standard, and it helps to get rid of the white coat hypertension and identify those with masked hypertension. And I'll explain what those are in due course. It says check to see if their kidneys are still leaking protein, and then check their lipid profile, i.e. their metabolic profile, and their body mass in terms of their long-term risks of cardiovascular disease. And it says thereafter, yearly review. No other guideline says that. It just says women should be followed up and be told their risk is high. And I think this is brilliant, because it's giving very clear guidelines that people should be seen at 3 to 6 and yearly thereafter with the same checks. So the failings in both the SOMANs, but more so even in the ESC, the European that is, and the American, is that none of them provide a detailed protocol which either secondary care or primary care can follow. While often they say that 6 weeks postpartum is a really important time to check, they don't say what we do between that healthcare visit in that first 10 days and week 6. And as I hope you'll see in a minute, this 6-week period that obstetricians called the puerperium is absolutely the critical window where we need to be controlling their blood pressure well. And if we don't do it well in this period, we're almost missing the boat. And again, whilst they emphasize that the risk of cardiovascular disease is increased long-term, and thus we should advise on diet and lifestyle and risk factor, apart from your guidelines, no one gives a timeline or how to do this. But a massive change in the last 5 years is that they have taken a holistic approach and said that each time you come into contact with these women, it's a chance to counsel about future risk. Their risks are huge of further preeclampsia in the next pregnancy. And the SOMAN's guidelines quotes this as 7-fold. Our own guidelines quote it at about 5. But you want to count about risk of recurrence of this hypertensive pregnancy, risk of cardiovascular disease, the importance of contraception to allow the body to recover and not get pregnant again in that first 2 years, and risk modification strategies. Sadly, it's only aspirin with any data behind it of reducing risk at present. And again, that is the subject of other trials. So what does the real world evidence say in relation to what the guidelines say? So this top left box here is a summary from Marion Knight and Claire Carson, who run our maternal mortality and morbidity investigation that we term EMBRACE. You have something similar here. And they realized that actually what they were seeing in EMBRACE with maternal deaths was a mere tip of the iceberg. And when we dug down into some of the data, and our GP data is called CPRD, you get a lot more granular information. They looked at 30,000 women over the last 5 years and found that only just over 61% actually got a 6-week check, despite NICE saying everyone should have it. Less than 5% had their urine dipped. And those women that had the worst type of hypertensive pregnancy, i.e. they'd had it early, they'd had a preterm birth, and their babies had been small, we know these women have the worst phenotype and do worse long term. They had an even lower chance of having a 6-week check, below 50%. And only 56.4% had any BP measurement in the 4 to 12 week period after they'd seen that health visitor in the first 10 days. So how is the States doing? The States like to think that they're the gold standard bearers for many things in the world, and certainly they're not shy about saying they think they've got good healthcare, albeit it's a private model. Well, if we look at all comers, only 13% of women in the US get a postpartum BP check. And if you're Black, less than 10%. What does your local data say? So this is data that I was only showing yesterday, and I'm going to thank Nikki Earle for providing these slides, and Sue Warren, I think many of you will know. So this work's been done as a larger project looking at multimorbidity and cardiovascular risk in people registered with ProCare. And in this particular summary, over 200,000 women below the age of 65 were assessed. And it's saying that the prevalence of hypertensive pregnancies, 4.6 to 4.7%, which I think is probably a massive underrepresentation given that every other study in the world shows that it's at least 10%. And more worryingly, in primary care, when you look at the number of women, only 0.1% of cases are being coded. 91% of cases are not visible. So there must be an issue with coding. We can discuss where this could be. And we certainly have had issues like this in the UK, where we've got 20 ICD-10 codes that the administrators in the hospital can code. And they often pick the top one, which is just hypertension rather than anything to do with hypertension in pregnancy. When they looked at the prevalence by ethnicity, it does seem to support the data in the rest of the world, where there is a higher incidence among ethnically minority groups, Black and Caribbean I mentioned earlier, but here Pacific and Maori, suggesting a lower incidence amongst Chinese and other Asian. In this same study of all 200,000 women, the long-term risk seems scarily high. So 72% of those who had a hypertensive pregnancy had a higher 5-year risk of cardiovascular disease, and they were presenting early, a median age of 46 at the time they had a major vascular event. These are scary stats. So, what's the latest evidence say? This is one of those slides where you're sort of I think was blowing your own trumpet. So these are some of the publications that have come out of our research group in the last few years, looking at the benefits that self-management can have at bridging this gap. So let's take a very brief look. I'm not going to take you through the papers in detail. You've all had a long day. So it started as a pilot study in just around 100 women to see, is self-management, i.e. giving women a blood pressure monitor and then remotely monitoring those readings and adjusting their medication to keep them in a range below 140/90, safe? Was it feasible and was it liked? And this feasibility study showed universally well above 95% in all those metrics that it was well liked, safe and feasible. It wasn't powered to detect blood pressure differences, but showed, and along the bottom here you've got timeline postpartum, and on the y-axis you've got the blood pressure, and then the percentages are those number of women taking medications. Red here is the intervention arm, the self-management. Control is the people being looked after by GP, nurses and midwives, and typically it's midwife and GPs in our country in the first year. And it showed that it was clearly a pattern, and actually it reached statistical significance by 6 months, and there was about a 5mm difference. I then followed the same cohort of women at approximately 4 years postpartum, and these widen, even when you adjust for traditional risk factors such as diet and salt and family history and smoking and levels of exercise. These gaps widen. So it suggested that intervention early seems to alter your lifetime trajectory. So by 4 years, that gap that would have been 5 had widened to 7. So we then did a definitive trial called POP-HT. There's obviously a theme. We like Rice Krispies, which was to compare the same thing. We used slightly more modern monitors. So we used Bluetooth-enabled monitors so that the readings were captured accurately and make it easier for the women. And we took 220 women because that's what our power calculation said we needed to be able to detect statistical significance. So same slide. This is clinic blood pressures. So blood pressures you would do in primary care. And you can again see that antenatally they're very similar. And in fact, in this trial, the intervention arm had slightly higher BPs antenatally at baseline because more of them had had a prior hypertensive pregnancy just by chance. But by week weeks 1 to 6, you start to see separation, and it widens out to the 6 to 9 month period. And those differences were 5 millimeters systolic and diastolic, consistent with the first trial. And then when we looked at it with 24-hour blood pressure, which is a gold standard and more accurate, we see a 6 millimeter reduction in diastolic and 7 systolic. Putting that into significance, if you maintain that for a lifetime, that's a 30% risk in your risk of cardiovascular disease. As a cardiologist, we love doing pictures of the heart, so we also did lots and lots and lots of detailed scans using MRIs and echo, and we showed that your hearts are much better. So the hearts pump better, that's your systolic function. They relax better, that's your diastolic function. As a result, the filling chamber, called the atria, are smaller, and as a result, because the heart's not having to work so hard, it's not so thick and it's not so heavy. So they reversed their adverse phenotype back to almost like a normal pregnancy. What was the impact on readmissions? We have to talk about health economics. The data showed a 20% absolute risk reduction. It's so hard to get that with any drug. An NNT of only 5 to prevent 1 postnatal readmission. So the cost saving from this, let alone the psychosocial benefit to a woman and their partner, any children they already have, of not being separated from mum again after a traumatic birth, is huge. So that's the guidelines. That's what we can do if we follow trial evidence, allowing for the fact that obviously that was a trial setting. What's the practicalities? So how often should we be measuring blood pressure? So all the guidelines I've mentioned from Europe, America, and so on say very similar things. They suggest that gestational hypertension, they treat as a milder form of the disease. I disagree. But they say once daily between day 3 and 5, and then just follow the guidelines, day 10, and see a primary care at 2 and 6 weeks. For preeclampsia, they say if you're an inpatient, 4 times a day, but as soon as you're home, you're completely different, apparently. So it's just once a day, day 3 to 5, and then go to alternate days. Very little evidence behind any of this. And why is this not accurate? A massive Cochrane review by Lauren McGee from the UK, published 10 years ago, showed very clearly your systolic blood pressure peaks at day 5 to 7, and your diastolic peaks out to day 10. So therefore, you need to be monitoring it more closely in the first 10 days. We know for some unknown reason that the blood pressure spikes early evening in these conditions, and thus you must have an evening reading done, particularly if their morning BP was high and you're changing medications. And we know that at least 15% of hypertensive pregnancy doesn't even start until the baby is being delivered, which has completely got rid of the fallacy that the disease is caused by the placenta. So these people, the BP continues to become aggressive and labile and spike right out to day 14. So the minimum requirement is that we're monitoring the blood pressure daily for days 1 to 14. And if their blood pressure is up and down or rising, twice daily. So what treatment should we be threshold should we be giving treatment at? So NICE, which is our National Institute for Clinical Excellence in the UK, the American Heart Association, European Society of Surgeons, all suggest that if you've only developed a problem with the blood pressure after delivery, so-called, as I said, 4th trimester hypertensive disorder, you don't even need to start treatment until 150 over 100. And what about those who were already on drugs because they had preeclampsia before delivery? So they only say to continue for below 140/90. What does the data say? So in POP-HT, those who were below 120/70, which is actually the new threshold for a normal BP, if your blood pressure was below this in that first 14 days, whether you were on or off treatment, you had a less than 1% chance of being hypertensive when we studied you at 9 months. If, however, your BP was above the traditional threshold of 140/90, 70% of women were hypertensive. So these thresholds are historical, they're out of date, and they need updating. There are big trials ongoing in UK and US now to adjust these thresholds. So my personal practice, and what we're now doing in our multi-center trial called SNAP-2, is that if the blood pressure is above 135/85 on home monitoring, because this is home monitoring when you're self-managing, or 140/90 beyond 14 days, we need to be treating. We should not be waiting for 150 or over 100, because that is driving adverse cardiovascular remodeling that's leading to the long-term risk. The Americans have taken this on board, and they've created this very, very good postpartum toolkit that just came out last year. And they say key things that support what I'm saying. They say monitor blood pressure 1 to 2 times daily in the first 2 weeks. The busy slides are just focused on the bits I've highlighted. And they say don't down titrate. Keep the blood pressure as low as you can if people aren't falling over and are too dizzy. until they're persistently below 110 to 120 over 60 to 70. So they have recognized that the thresholds need to change. Stress, one of my favorite slides I give in any hypertension talk, as well as obviously talking to the women about low salt fruit and vegetables, which we know are good. Stress has a massive impact, as sleep disturbance does. It's very hard when you've got a newborn baby or babies, if you've had a multi-pregnancy, to get regular sleep. Partners can help where possible, but not always possible in real world. Stress, this is one of my favorite slides. So this was a study from Cortona, which is in Tuscany, in Italy, and it looked at matched populations of women, of nuns, to matched community, eating a very similar Mediterranean diet, which we know is good for your heart, doing some levels of exercise at high altitude, and track them throughout their life. And the white bars are the nuns, and their blood pressure didn't shift. The black bars are the control population. You can see this is such an old study that the bars have started to fade, and their BP gradually increases by 5 millimeters every decade, which is why these thresholds I mentioned of self-management resetting you by 5 millimeters and appearing to widen is so important. And it's so important also to try and reduce stress at this time of life. So let's talk about what drugs should we use and when. So NICE and our British and Irish Hypertensive Society have tried to take the adult guidelines, which suggest A, C, and D, and keep life very simple. And I think it's a nice way of doing it. So they go A, C, and B. So if you're white Caucasian, A. If you're African or Caribbean, C. I can't yet find any data to suggest there's a benefit in a particular drug over another in the Maori population. And if someone has data on that, I'd love to discuss that in the questions. If A and C on their own aren't working, then you add them together. And if you need a third drug, you add in a beta blocker, which is the drug that people are often on most commonly antenatally, because it's got years of safety data behind it, and it's usually labetalol. You should avoid diuretics if you're breastfeeding, and ARBs like canazate and losartan don't yet have the safety data in breastfeeding or expressing. The two ACE inhibitors that do are enalapril and captopril. What if you're on 3 and it's still not enough? And we do see that occasionally. Then your options are driven by renal function, assuming kidneys are good. If the potassium's low, a bit like German adults, Spiro. But again, you can't give this in breastfeeding expressing, and it causes lots of GI upset. And dapamide is a good option if the potassium's high, but again, breastfeeding expressing, you can't use it. Unless you're back to doxazosin. Very, very good, very effective, but can cause profound hypertension. So you have to be very careful, and you must be doing your twice daily monitoring. And if the person happens to have pre-existing CKD, then hydralazine is very good and safe to titrate, and it's used antenatally too. So real-world titration experience. A lot of this was from the trials that we did, and there's about 500 women now in the trials that I've been involved in, and a lot of it's been in postpartum clinic, which I'm going to touch on at the end. So both enalapril and captopril are BD dosing. And this is really important, as I said, because these women get a rise in the blood pressure later evening. And so that BD dosing really helps to suppress that. It's really important to know that the way they work is by suppressing the renin, angiotensin, aldosterone system, which takes around 24 to 36 hours to turn off. So if you're starting this as a monotherapy drug, and you're in that period in the first few days where the BP really shoots up, you must be covering with a second drug. So either a rapid-acting calcium channel blocker like nifedipine, or a longer-acting such as amlodipine. And that often needs to stay for the first few days until the enalapril is fully effective. The enalapril needs to be titrated rapidly. People get very nervous, but within our trial, we were rapidly titrating from 2.5 to 20 BD within 2 days with no adverse events such as hypertension or AKI. And the real-world data in the UK has shown no significant adverse events in 6 years of real-world use. The only real, I'd say, caveat would be if a woman has got acute kidney injury because they'd had a cesarean, lost a lot of blood, then got sepsis, then given NSAID, I wouldn't start it until their kidney function had recovered. In terms of the babies, in the trial, we had to monitor all neonates. Many of them had neonates from the early onset preeclampsias on the neonatal intensives and special care units. None of the babies had low blood pressure. And again, we're not seeing any signal in the real world. Calcium channel blockers, nifedipine's particularly well liked in our country, but it requires dosing 3 times a day. It causes headaches in almost everyone and causes blood pressure lability. So my preference is to use a slow release PrEP, but it's still twice daily, or even better, amlodipine. If you're African or Caribbean, then the calcium channel blocker becomes first line and the ACE second line. but still good data to use that base. Labetalol, almost everyone seems to be discharged on it. It's an obstetric legacy. It's a terrible drug postnatally because you need high doses and often 4 times a day dose. It causes people to feel tired, become bradycardic, and causes lability. So my advice is wean it quickly, and this is a weaning schedule that we used. So over 3 days, you would really get off it quickly. You don't get rebound problems like people describe, and add enalapril and titrate it rapidly. So you do 2.5 to 5 to 10 BD to match that. Methyl dopa, all the guidelines say you should avoid it, and it's a horrible drug with side effects. I'd agree. And then doxazosin, as we've talked about, it's very good if you're struggling, but only need maybe 1 milligram, 2 milligram at most. And once you're beyond that day 14, you should get rid of it as soon as possible. So Bruce kindly provided me with a list of the blood pressure medications commonly used, and I'm very pleased to see that enalapril and captopril are right at the top, and that you also love amlodipine and felodipine. Amlodipine doesn't have any particular, trial data, but actually we're using it quite a lot in the UK now in our real world clinic, and it's very well tolerated. It's slow release, and for those people who don't like the ankle swelling with amlodipine, we swap them across to felodipine, and we're not seeing any problems. And that American postpartum toolkit that I showed you has all the drugs that they use in the States. You'll see that nifedipine, enalapril, and amlodipine, labetalol are at the top, but felodipine is fairly good and has emerging safety data to almost match. You'll hear these are the safest drugs highlighted up in the top 4. So Maori hypertension, this is an area I have no experience of. So this, full disclosure, is what ChatGPT told me. Several population studies suggest Maoris have high average blood pressures, that there are higher rates of hypertension when you compare to people of European descent, but a lot of it seems to be driven by BMI when you adjust. There's data suggesting there's a higher cardiovascular risk in Maori, and that long-term adherence to medication, including their blood pressure lowering, may be lower. If you are adherent and at higher risk, you actually tend to have better control, and there was no clear data to prove a pharmacological response. So this is something I think we really need to discuss, and I'd be keen to hear thoughts about people's real-world experience and any trial data they've been involved in. So telemonitoring, obviously, I've got a bias, but it's now at AHA and ESC recommended. This was the AHA guidance that came out last year, quoting our trial that shows the benefit. The European guidance from this summit also quotes our trials, but it's not just our trial. Karen Hoppe has done a very good trial showing that it's safe and effective, and again, 8-fold fewer hypertension-related admissions, which is a huge cost benefit as well as the psychological benefit. Sawyer and Allen States around the coronavirus pandemic did a big study, and it showed where less than 10% of women, remember, in America had a blood pressure check postpartum, had 90% compliance rates. More than 90% of women were being followed up for the full 6 months. And not only is it good, but it's well liked. So what is good news here? So this is what I've found out from being at a talk hosted yesterday at Auckland, and from visiting out to Middleton today to Isabella Smart, who's one of the midwives leading a digital cardiology program, and from some of the Auckland midwives, Rachel Taylor and New McGuinness, who kindly shared some resources. So you already have a lot of this in place. You've got protocols for self-monitoring, which are embedded based on the SOMAN's guidelines. You've got the equipment, and it appears to be that you've got the support. So actually getting a self-management, i.e. telemonitoring and adjusting to the self-monitoring, wouldn't be a big step. This is a guideline from Auckland. Again, very busy. Just look at the bits highlighted. It tells you, as the SOMAN say, you should be monitoring daily for at least 7 days. I like this because we have this in our hospital, that a discharge letter should be given to GPs about future pregnancy risk, and a copy will be given to the woman, and a 6-week natal visit will be arranged. This doesn't happen in our hospital. I'd be intrigued to hear if it happens over here. It also says they should receive information on long-term risks. I don't think at the time of discharge this is the right time. As I've mentioned earlier, there's a lot going on. And again, it quotes the SOMAN's guidelines here about monitoring the blood pressure, the lipids, and the long-term risk, and therefore seeing them annually. These guidelines still go for the 140/90, but as I talked about earlier, there's a lot of evidence that that's too high. But the guidelines here, to be fair, haven't updated since the trials came out. These are some of the other things that the women are provided with. So they get this leaflet. It tells them why they're being asked to take it. They're listed the medications. There's a diary also included. And they have a lovely traffic light system, which is very similar to the traffic light system we used in the SNAP and POP trials. So what have we discussed so far? Pregnancy hypertension is associated with a huge risk of later cardiovascular disease. Postpartum period and your blood pressure control closely relates to this long-term risk, albeit these come from observational studies. But we know from randomized trials, including my own, that if you modify the blood pressure in the short and medium term out to 9 months, that you can improve blood pressure control out to 4 years. That's what the SNAP-HT extension study showed, and alter cardiovascular remodeling. Sorry, jumped ahead, but we're ready for the slide anyway. So what's next in Auckland and beyond? These are the areas I discovered that your 20 DBs, delivery care boards, DCBs, have now come down into. We keep going through cycles with every government too, where we keep renaming our healthcare trusts or boards. I'm not going to embarrass myself trying to pronounce them all, as it's late in the evening and I've been talking lots today. But there are 5 key areas. All have got their own challenges and nuances. In the east and south, which is where I was today at Middleton, they have some really good virtual monitoring programs or virtual wards, which they're being used for general adult hypertension and other cardiac problems. There's a potential to easily transition into self-management of postpartum blood pressure, and the midwives are keen in the hospital to work with primary care to deliver this. What we're doing in the UK is we've evolved the POP-HT into an app called My BP Care, which you can download from Android or Apple Store if you wanted to have a play, and it works over here. And these are examples. So the left screen here is exactly what the woman sees. They can enter their blood pressure, they can look at their history, see their medication, and then all the messages which are automatically generated in response to their blood pressure, i.e. this is perfect, this is high, this is low, tell us what your symptoms are on this screen. This is how they enter their readings. This is their history, and these are the messages. And this is a little summary page they can look at for getting more details. As a healthcare professional, you log on to a web-based server, and I could do this now real time by just typing in a particular web address and logging in with my username and password, and I would see these sample patients. And here you see their names, how many days postpartum, and thus you can predict if their BP is going to be stable up or down, how well compliant they are, have they confirmed the medications, have they reported any side effects, and then this is the traffic light system, which is aligned very much to your system that I showed on the Auckland City Hospital. These are what their last BPs are, whether they should be once or twice daily, and if there's been a flag about a prescription change. In SNAP-2, which is the evolution from POP, where we're looking at just shy of 1,000 women across 12 hospital sites, we wanted to see if GPs could replicate what we did as hospital physicians in POP. So all the duty doctors get this email, and it highlights, and again, lots on the slide, just focus on the red circle, that this is an urgent matter. This lady's blood pressure is high. It's 190, 135. Up titration could be by increasing the medication or adding more, and there's a link to say exactly what they can do if you're not familiar and you haven't got the expertise, and that's based on the trial and real-world data. Because it's so high, it also tells you in the actions that they must have a face-to-face assessment and or hospital admission today. But for the lower BPs, it will just tell you about adjusting, issuing a new prescription, recording in the notes, and that their readings will carry on. So how do we make this work here? So there are clear barriers, like there are in any healthcare system, to funding. It appears that it's midwife-led care in the 6-week postnatal period, which is the vital period I've just discussed. Midwives can't prescribe antihypertensives, which is the same as in the UK. There's cultural differences versus the UK, and I don't have the Maori and Pacifica experience, but certainly we found in our trials that engaging ethnic minorities, whether it's in research or in the real world, and keeping them engaged is a lot more difficult, and we therefore need to work on co-designing interventions and real-world care. And the difficulty is the transition of care from midwives to primary care at that week 6 period. So how do we do that here? So what they're thinking of doing in Middleton and what they're doing beyond Middleton for various other problems antenatally, whether that's gestational diabetes or just education about breastfeeding, sleeping, latching, is they're using a platform called Datos Digital, which is very similar to the BP Care app, and they're using home monitoring metrics, whether it's this patch that sticks to the thing called BioBeat or monitors like the ones we use in the trial. And this allows people to be monitored at home safely and have their medications adjusted. So I think this is the real step here that needs to happen locally in New Zealand to translate SNAP and POP into New Zealand. Thank you very much for listening. I know you've all probably had a very long day, and it's a fairly long session with a lot of information in an area you may not all be familiar with. So thank you for listening. Thank you to the Auckland Medical Research Foundation and Larry Chamley for having me over to do a series of talks this week. And thank you to Bruce and the Goodfellow unit for allowing me the honor of presenting to you. And all of the people on the right are the people who've been working behind the scenes and with us throughout the last 10 years to deliver this body of work. I'm going to stop sharing, and we have time for questions.
So a bit surprised to see 135/85 as a threshold for treatment. Obviously, I guess a couple of questions there. In our heads, we've got to consider these people. I mean, that in a not in a non-postpartum woman would be probably pretty good control from my point of view. But you've obviously got to think this is a high-risk woman. So how do we make that shift? I mean, it's quite a big cognitive shift.
It's a good question. So in both America and Europe, the guidelines have now changed so that we now treat on home blood pressures above 135/85. That is the new threshold for hypertension. America used 130/80, in fact. Clinic BPs are not particularly well liked anymore. So people who are young, we either use home BP or ideally 24-hour blood pressure if it's available, because as I said, 24-hour blood pressure has the ability to, identify those who have white coat, where there's a discrepancy of either 20 systolic or 10 diastolic between the clinic reading and the average on the 24-hour monitor. And similarly, home BP has an emerging data set behind it that it also has that ability to discriminate a bit of masked and white coat, albeit you can't get home blood pressure readings at night. So I think the first point of it is we need to reset our entire mindset about general hypertension, and that actually the old 140/90 was too high, and we need to be bringing BPs below 130/80. And in those people with kidney disease and other comorbidities, even lower. And Sprint showed that the lower the better. There are huge studies in almost hundreds of thousands of people in China that have mirrored Sprint at all age groups. I think in this cohort, it's such an aggressive condition that you see adverse cardiac, vascular, and brain remodeling. We've got brain data that's just coming out in JAMA Neurology in a week or so's time, that shows you can actually, even in this period where we're improving blood pressure in the first few months, alter brain volumes within the first year, which is, incredible. It's such an aggressive condition that it's causing end organ damage in every key organ. And so we really have to bring the blood pressure down quickly and keep it down to stop this end organ damage happening, which alters their trajectory for life.
I'm interested, you mentioned in one of your studies about the diastolic blood pressure. We've sort of gone away a bit from diastolic blood pressures here, and mainly our guidelines actually use systolic blood pressure only. What's your view on that? Is diastolic coming back in? It was there when I graduated, but that was 40 years ago.
So I think the first study that put diastolic on the map was the Framingham Heart Study, which was, middle-class white Americans. But it showed that if you were young, i.e. below 50, diastolic blood pressure was the primary driver of you going into later combined systolic diastolic hypertension. It then sort of fell out of favor through various guidelines, but it's now come back. And increasingly in young people, we recognize that diastolic hypertension is often the precursor to getting later combined. There are a small number that get isolated systolic. That tends to be more people with secondary causes and in people who are African or Caribbean. In hypertensive pregnancy, if you look at the biggest cohort studies in the world, which come from Norway, they're called the Hunt studies. They've got over 38,000 people in. It's the diastolic blood pressure that never returns to normal. So it's diastolic, and that's why in our trials we chose diastolic blood pressure as the primary outcome. So it's the diastolic BP that goes first, and that diastolic BP is probably linked to the cardiovascular remodeling we've seen in the trial. We've seen that the vascular stiffness goes up, and you can bring it down by self-management intervention, and the diastology is altered, and those combinations of the cardiac diastology and the vascular stiffness lead to diastolic hypertension, which in turn, untreated, leads to systolic hypertension and mixed.
We have some scary data here about heart failure in Maori versus European. The average age of onset in Maori is 63 years. In European, it's 80 years. That's a 17-year.
It'd be intriguing to correlate that to their diastolic BPs.
Yes. No, it would be, if we could look back. So a question here from Josephine: could you please talk more about delay until the person becomes pregnant again?
I'm not an obstetrician, but obstetricians that sit in my multidisciplinary clinic that we run generally counsel women not to get pregnant again if they've had a cesarean section, because of the risk of uterine rupture, which is highest in the first 12 months and goes down to below 1% by 2 years. So they generally give them that stat in the clinic. From a cardiologist viewpoint, we know that this has been a huge stress test, that we need that 9-month period to try and get the reverse remodeling back to normal. And if they happen to get pregnant again during this period, the incidence of them getting preeclampsia, again, or a milder phenotype like gestational hypertension is exceedingly high.
Are smartwatches good enough for BP measurement? Do you recommend a particular brand of sigmo-manometer?
Yes, it's a good question. So simple answer is, as the current data stands, no. The biggest smartwatch study was the Apple Heartwatch study, and they principally were looking at heart rhythm, and all of these smartwatches use something called PPG. So it's essentially a sensor shining a light into your capillaries, getting a reading back, and from it deriving heart rate, oxygen saturations, and blood pressure. The accuracy for the Apple Watch study was for heart rate about 70%, for blood pressure about 50%. So I would never approve of a medical device with an accuracy of 50%.
My thinking is being the Omron are a pretty good brand. Is that a UK brand?
So Omron are the monitors we use. We use wireless monitors, ARM-based. They've now got some devices out that appear to be much better. They've got a ring. But I've yet to see the data, and I think it's really important that any data is validated in a pregnant and postpartum population. And so you can't generalize any validation study in adults 18 to 65 to a pregnant cohort and to a postpartum cohort, because they are different conditions. So I think wearables will come. I was having the same discussion today with Middletown. They're using this BioBeat, which has been validated in against your national early warning scores, and it collects 5 parameters: temperature, heart rate, rest rate, sats, and blood pressure. And they've got fairly good data that it's reliable for conditions like sepsis and COPD. But again, it's never been validated in this sort of cohort. And it would, if we are going to start to do it, I think it would be a great opportunity to test it against the gold standard, which would be an Omron arm cuff or a Microlife Watchman, which is what Andy Shannon uses in all his studies in Africa.
So I had read ARB should be avoided in breastfeeding, unknown safety to the infant.
Correct. So it's enalapril or captopril. We tend to use enalapril because that was what Lucy Chappell, who wrote our guidelines, decided to put in as first line. And now we've got 6 years of data on it. But captopril we've been using for years for peripartum cardiomyopathy, and it works very well. It's just a bit more fiddly to titrate.
When you say ring, do you mean like a ring for measuring blood pressure?
Yeah, like a wedding ring, and an Omron have just brought one out, and they're looking to validate it.
Wow. So if the BP is well managed in postpartum hypertension, patients ongoing, does the remodeling not happen, or is there some remodeling regardless?
Yeah, no, very good question. So when we looked at the POP cohort, you never get back to a completely normal state of what a normal tensive pregnancy heart would look like, but you get about 75 to 80% of the reverse remodeling fixed in the intervention arm. We're going to study the same cohort now. They're all 5 years. So we've just got funding from the BHF to do a 5-year follow-up study. So we will watch this space, be able to tell you if the reverse remodeling stays or if it's lost.
So you recommend treating blood pressure. I noticed you mentioned lipids at some point. Would you treat people with statins if their LDLs are up?
So none of our conventional risk scores, and there's all sorts of scores. We use Q-Risk 3 in the UK. Q-Risk 4 is about to come out, and for the first time includes hypertensive pregnancy as an independent risk factor. Europeans use SCORE and SCORE 2. The Americans use ASCVD. I'm not sure the scoring system used here. None of them are particularly very good in young women who've had a hypertensive pregnancy. So I, in my practice, tend to take a approach of looking at their overall risk. So if they've had a very bad hypertensive pregnancy, if they've got a really high LDL, if their BMI is high, they've got a family history, I don't believe what Q-Risk score tells me. I counsel them to say I'd have a low threshold if you're not planning another baby, and your LDL's 4.5, and your blood pressure's been high throughout and we're still treating you, and your BMI is above 30. I then check a lipoprotein A level, because there's good data that obviously links to their risk and it's non-modifiable. And if that is also up, I would then advise them strongly to start a statin. We're actually doing that trial now, so we don't understand what drives the cardiovascular risk in terms of heart attack. So one of my research fellows is currently doing CT coronary angiograms at low dose on women who are around 10 years postpartum to see, do they have more plaque than normotensive? Or do they have more fat around the artery? So one theory is it's driven by fat around the coronary artery. It's called perivascular fat. So in about 4 years, when she's recruited enough women to this, we'll be able to hopefully give you a better answer.
So if you're treating people with statins, what do you drive the LDL down to?
Our guidelines say lower it 20% from your starting point if it's for primary prevention. And obviously, if they're planning future pregnancies, we don't go down that route till they've completed their number of children they've had, because stopping and starting is difficult.
So any other medication apart from labetalol during pregnancy?
We tend to use, in our country, I'm not an obstetrician again, just to signpost that, but the women are generally on labetalol, nifedipine, and then methyl-dopa tends to get added as a sort of late stage before they go for their emergency cesareans. But I think by the time they've broken through max dose labetalol, nifedipine, they're heading to the surgeon.
Here's a long question here. I'll read it out because it's too hard to abbreviate. Currently, I have a patient 6 weeks postpartum on labetalol and BD captopril since discharge. Compliance is an issue with BD dose, and she has just restarted Ritalin long-acting for ADHD, I presume. So monitoring BP at home regularly. BP well controlled around 130/80. Is it okay at this stage to do once daily dosing of ACE and possibly calcium channel blocker labetalol to be stopped?
The suggestion is excellent. So I think the key there is to get rid of the labetalol, because it's got no data behind it postnatally it being particularly effective. If she wants to reduce her tablet burden, a once daily calcium channel blocker amlodipine would be great at 5. See how the BPs are, and if the BPs are stable, you could look at going to once daily captopril and having the amlodipine in the evening and the captopril in the morning, trying to prevent that spike. But once you're in the 6-week period, you're coming into the sort of easier to control part of the disease. So I wouldn't go straight away to once a day if you're going to stop the labetalol, but I would certainly say if you've got good home monitoring, you can certainly look at it a week or so later.
From your earlier comment, the cardiac remodeling takes 9 months to reverse. Does this imply the treatment should be continued for at least 9 months, irrespective of blood pressure readings?
We can't actually say that. So we studied them at approximately 9 months. It was 249 days mean, about 8 and a bit months postpartum. So that's the time point we looked at that we saw the remodeling had reversed. Putting a woman in an MRI scanner any sooner was going to be quite tricky. And we did echoes at baseline when they'd just given birth, and again at the same time they had their MRI. So we can't say from our research the time point at which remodeling has occurred. A very good obstetrician called Baski Philingathan from St. George's has done a lot of work on this. If people are interested and want to read his papers, he has done some longitudinal echo studies, and he suggested that it takes 6 months, and therefore keeping the medication going, or certainly keeping the blood pressure low for that first 6 months, is important. And we know from other big studies in the UK, like Phoenix, which was a comparison of early delivery versus standard delivery to see if that improved outcomes, that they did a sub-study with echo, and that if your echo is abnormal at 6 months, you tended to run into big trouble by 3 years postpartum.
Right.
So I think the role of the, not really answered it. We don't know when the reverse modeling is happening. It's definitely happening in the first 6 weeks, and that's really important. When exactly it's happening between 6 weeks and 6 months is not clear until we scan people a lot more regularly. But the key is keeping the BP low during that period. And we know from lots of studies in heart failure and, various cardiomyopathies that ACE inhibitors appear to be beneficial, and that the longer you're on them, the better. There's a small study called Pickup, which suggests that if you add enalapril to other drugs, such as calcium channel blockers or labetalol, there is an additive benefit to having the ACE inhibitor on board. We didn't look at that specifically in POP because we weren't powered enough to do it.
So there's a complicated question about a sustained AKI, acute kidney injury, with their PET would not be wise, correct. Sometimes PIH and PET patients are discharged with an ACE and they have sustained an AKI, and we see them in clinic and tempted to stop, though I know serum creatinine can go up slightly with ACE use. What should we do here? My understanding is you're allowed up to a 50% increase in creatinine when you start an ACE.
So I think it's really important to check this. Like, obviously, when women are pregnant, they have ultrafiltration through their glomeruli. So all women will have, assuming they had normal renal function before, have a low creatinine, and creatinines will then go up by about 25 to 30% in a normal pregnancy after you deliver, because you restore normal circulating volume and you lose the ultrafiltration. So if you look at the traditional definition of AKI, which is a 20 to 25% increase, almost every woman has an AKI. So I think it's really important to check, actually, is this a genuine AKI, or is it just the fact that their creatinines go back to normal? If it's generally an AKI, and they had a creatinine at the day of delivery, after they delivered, that was 80, and they had a creatinine 3 days later, it's 120, you need to think about why. Generally that's because they've lost blood, or because they've been given non-steroidals or another drug that's particularly not great for the kidney, or they've got superimposed sepsis, or they've got into retention. And certainly if you've got a genuine AKI, you wouldn't want to start an ACE inhibitor to superimpose it. But the reason that people were traditionally reticent about ACE inhibitors was renal artery stenosis. And, the instance of renal artery stenosis in young women is incredibly rare. So I would say, if you see an AKI, think about the reasons why. Is it pre-renal, renal, or post-renal? Think about how that needs to be investigated and fixed, but get them back on the enalapril as soon as you can, but just monitor the kidneys more closely. Certainly, I've not seen any genuine AKIs with enalapril use in over 500 women in trials and 1,000 women in real life practice.
In non-pregnant adults, do you usually use it twice a day? I've always felt it was a twice a day medication.
Yeah. So I don't tend to use it in general. So I tend to use an ARB because you don't worry about the cough, and you give it once a day.
Hallelujah. I'm with you there, sir.
And so once they've got breastfeeding and it's 9 months, transition them across to our once a day if they still need a drug.
Yeah. No, we've pretty well gone away from ACEs. Just got so sick of the coughing.
Yeah.
We used to have to make people cough on 2 different ACEs before we could get an ARB at one point. So we're very sensitive to the ACE coughs. I never use them. Is there any difference in cardiac remodeling between peripartum cardiomyopathy and hypertensive disorder of pregnancy?
Yes, that's a good question. So there's an overlap between the two conditions. So the general incidence varies in publications. There's about 1 in 5,000 pregnancies, but if you've had a hypertensive pregnancy, it's about 1 in 600 to 1 in 700. So it's much more common. In hypertensive disorders of pregnancy, what you tend to see is the septum in the heart, which separates the right and left ventricles, gets thicker. The mass goes up. The diastolic function drops, and the left atrium stretches. And the aorta becomes stiffer. In peripartum cardiomyopathy, you get a very different pattern. The heart dilates, the volumes get bigger, and your systolic function drops. So it's a very different pattern of remodeling. But there isn't driver, as in a hypertensive pregnancy can drive you if you have a substrate in your heart. This is the second hit hypothesis. The hypertension drives you into the peripartum cardiomyopathy. But the drugs you use are very much the same. So enalapril would be the first one, and then you would be obviously giving diuretics, and then you would be adding beta blockers and the newer drugs like SGLT2 inhibitors, dapagliflozin, empagliflozin, and mineralocorticoid receptor antagonists such as eplerenone and Spiro. none of which, of course, you can take when you're breastfeeding. And obviously, stopping breastfeeding is one of the most important things you can do in that condition, which is very hard for the women.
Problem with spironolactone and breastfeeding?
Yes, there is. It's completely contraindicated.
Okay.
It transmits into the milk and it upsets the RAS system in the baby. I think it's got high levels of transmission.
Okay, so this is from a midwife. Thank you so much, Fiona. Fascinating. I'm a midwife and agree that transfers to GPs is an issue. I'm in Hamilton, which is about 70 miles to the south, and women here do not come back to the hospital for a postpartum appointment. Is this the gold standard? I don't think our system could cope, meaning they don't come back to the hospital, they go to their GPs. Well,
Yeah, that's sort of what I was alluding to in the last few slides. I think, the window opportunity to get these people engaged is on the postnatal ward, and I think that's where you can set them up with the home monitoring. And then it's going to be, I think, depending on your individual setup within the community. So, whether it's the midwives who are going to do the monitoring and the hospital send 6 weeks home of 6 weeks worth of medication that the midwives titrate with support from either primary care or from the hospital. I appreciate that the funding model is that the midwives receive the bulk of the money, from what I understand, in that 6-week period. But, if in Hamilton you don't have access to the RMO or SMO in the hospital, and you've got a GP who cares about the patients and who's willing to, provide this and can perhaps claim back for the extra input, if they've got the home monitoring, then you can ask the GP picking up the phone to prescribe the medication, and then you can supervise the titration.
Okay, so a question about proteinuria here. I noticed you mentioned doing dipsticks. I always thought they were a bit dodgy dipsticks. We can also measure ACR. We get a microalbumin. Do you have any preference for that? I know that they're expensive, the ACR.
If your dip's completely clear, there's no point wasting your money, essentially. And that's I sit in my clinic with a renal physician who's very, very good, and she's in obstetric medicine. So we dip the urine in clinic. If there's a trace of protein, we'll send an ACR. But if it's got nothing at all, there is no point. It's got a 99.9% rule out. If you've got a 1+ or 2+ or 3+, you obviously have to quantify it. And if you do have persistent proteinuria at 3 to 6 months, your risk of CKD is again off the scale high. So you should definitely be considering continuing the ACE inhibitor in the longer term.
Yeah, so no hurry. Yeah, that was a question. How does persisting proteinuria affect the management of BP? And I guess you answered that.
Yeah, to 125/75 or below.
Okay, in the context of hypertension pregnancy, I recall an obstetric physician talking about the upper limit of normal for serum creatinine being lower in pregnancy. I think you mentioned that. Is this true? Diagnosis of AKI was serum creatinine of 85. Not sure whether you can make anything of that. Could you perhaps, anonymous attendee, just rewrite what your question is there? We're not following it.
I mean, if they had a creatinine booking of 85 and a creatinine at the end is 85, then that's not an AKI. It means they got pre-existing renal disease. If the creatinine was 55 the day before delivery and 85 after, I'd again argue that potentially isn't an AKI. It's just a change in the filtration. You need to see a trend. And a creatinine is a spot check at one point in time, complete dependent on the fluid status. So it's not the best way to diagnose AKI.
Question about methablopra for hypertension and pregnancy. I think you're suggesting it's sort of third line. Is that right?
Postnatally, almost all guidelines say not to use it. Postnatally, it causes a lot of side effects, and some data suggesting it's dangerous. Antenatally, it is used as it tends to be a third-line agent after labetalol, lifedipine. Sometimes hydralazine added, and then methodopa is a sort of an attempt to try and get a little bit further. Perhaps they need to get to the point where the fetal lungs are matured with the steroids. So it's a sort of last-ditch drug.
Fiona's saying GPs are funded for 6-week check and can complain single service fees in pregnancy too. Oh, that's nice to know. So funding is a struggle for the continued care. I'm from Canterbury, where we don't have this messaging systems. So I think she's thinking about something you mentioned earlier.
Yeah, and I think that's the real key here is that you've obviously got this now overarching New Zealand healthcare that's trying to join things up. Again, staying away from politics. You've obviously got the 5 different regions. I certainly within other areas, counties in Monaco virtual heart failure wards are now taking over patients that are in north, west, as well as their own in Eastern Monaco. So they are spreading. They're even looking after some people in the South Island with gestational diabetes antenatally. There's an extra pot of money, from what I understand, that's coming centrally. So I think if they do get this pilot going, they're more than willing to offer services, and I think they'd be keen to pilot it and show that it could be rolled out. It just requires the person who's on the ground to have a login. They can then monitor their patient's vitals and blood pressure, and they'll be the ones actually changing the drugs. But there's a centralized area, so that out of hours they provide 24/7, and they actually have buy-in from St. John's Ambulance. So it's a great service, and I think it's a great opportunity to spread this. New Zealand North.
Some people and say, yes, methyl dope is still available here. Thank you for that, team. I knew somebody would know the answer. Well, I think
They do still exist.
depression was a common problem, I think, with methyl dope.
Yeah, and that's why it's gone from the guidelines, because there's very good data series showing that it exacerbates postnatal depression and psychosis.
Yeah. Okay. Well, we've got through all the questions. That's fantastic. Do you want to just summarize? Well, what's the take-home message? We have a saying, skills for next Monday, Jamie. So tomorrow's Wednesday. So what would you like us to take away from your talk today?
I think the key point I want people to take away is that you must monitor, ideally twice daily for the first 2 weeks, that you must act if the blood pressure is going persistently above 140/90. If I can get you to 135 and 85 in due course, I'll be happy, but 140/90 will be a starting point. And that these people must transition. That's 3 points I've given you, but they must transition if they're having ongoing hypertension or proteinuria, or there are other associated problems such as diabetes, that they must transition to primary care for ongoing risk assessment and management long term.
Right. So that's a really great take-home message. So thank you very much for doing this. A little bit jet-lagged, I appreciate. And we're very grateful that you've come to this neck of the woods, a long way from the UK. And thank you very much for your talk, and thank the audience for being here tonight.
Thank you. Excellent questions. Thank you.